Hello, everyone. Thank you for joining today's Web Interface support call. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone and the support call questions box, and the CMS subject matter experts will address as many questions as time allows. Also to note, a recording of the slide deck from today's call will be posted to the QPP webinar library within the next 2 weeks. Now I will turn it over to Sandra Adams-Slaughter at CMS to begin.
Thank you, Haley. Welcome, everyone, and thank you for joining us today as ACOs prepare for quality reporting. I'm Sandra Adams-Slaughter from CMS. Joining me on the call today are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions following today's presentation. Today's call will only focus on the 2023 CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Today's slide deck recording and transcript will be available on the QPP resource library within the next 2 weeks. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation is current at the time it was published. But I urge you to please be sure that you are using the source documents and links that are provided throughout the presentation. Next slide, please. And next slide. The CMS Web Interface will close at 8 p.m. Eastern Time on April 1st, 2024. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. Dates for all upcoming biweekly support calls are listed on this slide. More information and registration links can be found in the 2023 CMS Web Interface support flyer. Next slide, please. The CMS Web Interface Application Programming Interface, or API, is available all year for testing in the developer preview environment. Please review the links listed here for more information. Next slide, please. Next, Katie Moore will review frequently asked measure questions.
Thank you, Sandra. The first measure that we're going to be covering today is PREV5, breast cancer screening. Here we'll just do an overview of the measure. So the intent of the measure is for women aged 50 to 74 years of age to have a screening mammogram for breast cancer during the 27 months prior to the end of the measurement period. In regard to the use of telehealth, documentation for breast cancer may be completed during the telehealth encounter. The medical record documentation must include the date the screening was performed, type of test, and the result or finding. Next slide, please. Now we'll cover some frequently asked questions about PREV5. For the 2023 CMS Web Interface PREV5 breast cancer screening measure, does a unilateral mammogram count for the numerator? The answer is that a unilateral mammogram counts only if there's medical record documentation of a mastectomy of the other breast. If only one breast is present, unilateral screening or one side must be performed on the remaining breast. Question 2, the 2023 Prep 5 coding document only includes link codes to represent mammograms on the numerator codes tab. And CPT codes such as 77065, 77066, and 77067 that are billed on claims with supporting documentation available be used. The answer is that if you're mapping to an electronic health record, you must use the coding within the Prep 5 coding document. The coding provided within the coding documents are considered all-inclusive when mapping to an EHR. If you're not mapping to an EHR, the coding documents may be used as a guide to assist in reporting. Other coding representative of the numerator quality action, denominator inclusion criteria, or reference exclusions and exceptions may be used to assist in locating the required medical record documentation. Question 3. The description of the 2023 CMS Web Interface Prep 5 measure specification states women 50 to 74 years of age, while the initial population states women 51 through 74 years of age on date of encounter. Which is correct? The answer is that the patient isn't considered eligible for the denominator until age 51, but mammograms received beginning at age 50 can be used to satisfy the numerator. The look-back period allows for mammogram during the measurement year, the year prior to the measurement year, and a 3-month grace period for a total of 27 months. Question 4, is it acceptable for the patient to report previous receipt of a mammogram, and can it be done during a telehealth visit? The answer is yes, as long as the documentation includes date, type of test, and the finding or result. Documentation of normal or abnormal is acceptable. Documentation of screening for breast cancer may be completed during a telehealth encounter. Next slide, please. Question 5, how is CMS handling gender identity for quality metric inclusion? Do you only follow the legal sex, or are there other identifiers considered? The response is that generally CMS considers the patient's gender at birth for inclusion in the denominator. If there's an instance where the patient was sampled for the measure, but you don't believe they should have been, for example, if they were born male but identify or have transitioned to female, we suggested submitting a request for another CMS-approved reason to skip the patient. CMS will evaluate each request on a case-by-case basis. In the instance a patient's demographic information is incorrect, it can be fixed within the CMS Web Interface. Note that any demographic information you changed in the web interface doesn't get reported back to Medicare Patient Enrollment Database. You should encourage your patient to contact the Social Security Administration directly to have such information updated. Question 6, if a patient has more than one mammogram in 2023, which one should be used for reporting? The response is that you're not required to choose which screening to use for reporting purposes. Within the CMS Web Interface, submitters are only required to confirm if a screen for breast cancer occurred within the appropriate time frame. Your medical record documentation must support that one or more mammograms occurred during the measurement period. Next slide, please. Okay, now we'll move on to Prep 6, colorectal cancer screening. The intent of this measure is to screen patients who are 45 to 75 years of age for colorectal cancer. In regard to use of telehealth, documentation of colorectal cancer screening may be completed during a telehealth encounter. Next slide, please. Okay, now we will cover some frequently asked questions related to Prep 6. Question 1, does a Cologuard test count for the 2023 Prep 6 measure? The answer is yes. A FIT DNA during the measurement period or the 2 years prior to the measurement period is acceptable for the measure. Question 2, does a FIT test, not FIT DNA, count for the Prep 6 measure? The answer is yes. A FIT test during the measurement period would be acceptable according to the Prep 6 coding document numerator codes based on the description of FOBT code variable. Question 3, if the FOBT is done in the office at the point of care and sent to a lab, is it acceptable for this measure? If not, Where must it be done to be valid? The answer is no. Per clarification with the measure steward, the intent is to exclude all FOBT tests performed in an office setting. Don't count digital rectal exams or FOBT tests performed in an office setting or performed on a sample collected via DRE. FOBT tests performed at home and brought into the office to be sent to a lab meet the intent and performance for the measure. Question 4, can we report FOBT results that are interpreted by our in-house labs? We understand that FOBTs obtained in the office or via DRE aren't acceptable. The response is, as long as the FOBT test itself wasn't performed in the office or performed on a sample collected via DRE, the test results are acceptable for the purpose of reporting the 2023 PREV6 measure. The measure specification isn't prescriptive on the type or location of a lab that can interpret an FOBT test, the type of colorectal cancer screening with the date it was performed, and the result or findings must be documented in the medical record to meet the intent of the measure. Next slide, please. Question 5, the initial population in the PREV6 measure specification states with a visit during the measurement period. We know the data can be documented during a telehealth visit. Is an office visit required if a telehealth visit has been done during the measurement period? The response is that the quality action isn't tied to a particular encounter, including telehealth, the clinician may have with a patient. If there's medical record documentation to support that a colorectal cancer screening was completed within the appropriate timeframe specified for the type of screen and the results are documented, then performance for the measure is met. Question 6, will epiprocolon, Steptin, Colovantage, Guardian, or other blood-based screenings be added to the list of acceptable colorectal cancer screenings for the 2023 PREV6 measure? The response is no. The numerator for the 2023 PREV6 measure doesn't include blood-based colorectal cancer screenings. The measure specification defines appropriate screenings as follows. FOBT during the measurement period, flexible sigmoidoscopy during the measurement period or the 4 years prior to the measurement period, colonoscopy during the measurement period or the 9 years prior to the measurement period, FIT DNA test during the measurement period or the 2 years prior to the measurement period, and CT colonoscopy during the measurement period or 4 years prior to the measurement period. Next slide, please. Okay, that concludes our frequently asked questions for today, and I will hand things back over to Sandra. Thank you.
Thank you, Katie. These next few slides will outline the available CMS Web Interface resources. Next slide, please. Please note that 2023 submission resources are available on the Quality Payment Program Resource Library. We encourage you to review these documents if you have questions on quality requirements and measures. Next slide, please. The recording, slides, and transcripts from the first 2 CMS Web Interface support calls are now available on the QPP webinar library. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. And now I'll hand things over to Haley to begin the Q&A session.
Thanks, Sandra. So we're now going to start the Q&A portion of the webinar. As a reminder, you can ask questions via the Q&A box or through the webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. So we have a few questions in the Q&A box. The first question we have is for Deb, and the question reads, Can a tobacco screening be completed in an ER setting to meet the measure?
Thank you. I'm going to go ahead and make a plug for one of the documents that has been provided. The FAQ document on what the web interface is posted on the CMS website. And the reason I bring that up is this very specific question is included in that document on page 36. The setting is not specified for the Prev 10 measure, and certainly we don't mind answering those questions here, but you may find that there are other questions within that FAQ document that will assist you as you complete the web interface. Thank you.
Thanks, Deb. The next question we have is for Carol, and the question reads, can you please clarify comfort care in regards to a hospice exclusion?
Hello, yes. Comfort care is not specifically defined within the specification. However, and there's no list of codes for CMS Web Interface measures to use for hospice or palliative care. But your medical record documentation should support that the patient was in hospice or was a non-hospice patient receiving patient goals or palliative goals or comfort care. Thank you. This is Carol.
Thanks, Carol. And then we have a couple of questions or a couple of hands raised in the attendees. The first hand is Lori. So Lori, we have unmuted your mic if you would like to unmute yourself. All right, Lori, if you have your question again, we're happy to circle back to you later. The next question we have over the line is from Brenda. So Brenda, we have unmuted your line if you would like to unmute yourself.
Can you hear me?
Yes, thank you.
Okay, so I have a question on the frailty exclusion, and I'm not even sure you can answer it, but I'm going to go ahead and try. In the frailty exclusion, there's a SNOMED code that involves a home, like a CPAP unit, and there's a SNOMED associated on the codes list. Our documentation clearly shows that the patient is on a home CPAP and uses it religiously, and that's part of the frailty exclusion. I have a colleague who's hesitant to take that exclusion because there's no code in the documentation. So like the documentation just reads that the patient's on a CPAP. Do you have to have the code on the documentation?
Hey, this is Katie. Can you please repeat your question?
Yeah, it's a doozy. We have a patient who we want to take the frailty exclusion. And one piece of that we're taking is that she's on a BiPAP or a CPAP. And that is one of the, like a home unit. And that is one of the pieces for the frailty, but there's no SNOMED code associated with the CPAP. Normally you see a SNOMED, I think it's like 702172008, which is on your codes list, like your Excel file. But the actual documentation just reads that, you know, the patient uses this religiously at home. So you don't have that SNOMED code in the documentation. Is the actual code required in the documentation?
Okay, so just to ensure that I'm capturing everything you said, so use of a CPAP is within the coding document for excluding patients. However, the particular code that you're referencing is not?
It's not in the documentation for the provider. So when you print out the order or the details, it just has, you know, may use CPAP when available. The patient uses the CPAP religiously at home, but it doesn't have like the actual SNOMED code on the documentation. So on the provider note, it doesn't have that specific code listed.
Okay, I see what you're saying. So in terms of reporting, as long as when you're referencing the coding documents, If your medical record documentation reflects, the code description, perhaps that would be acceptable to use as long as it's captured in those exclusion codes. So you wouldn't necessarily need to have the coding. The code description or something along those lines within your documentation would be used to support that.
Okay, that's what I was thinking too. Thank you.
You're welcome.
Thank you both for that question and answer. The next question we have is from the chat, and the question is for Carol, and the question reads, can we count a blood pressure reading if the patient is there for a colonoscopy visit? Carol?
Hi, this is Carol with the PIMS team. So for colonoscopies, if you have a diagnostic test or a therapeutic procedure, which is colonoscopy, that requires a change in the diet or a change in your medication on or 1 day prior to the infusion, it would be appropriate to move to the next most recent blood pressure to report. Thanks.
Thanks, Carol. And then we have Lisa on the line. Lisa, we have unmuted your line if you would like to unmute yourself.
Hi, I have a question regarding Prop 12. And there's been denominator exclusions. I'm a little vague on what is meant by or personality disorder, emotional liable anytime prior to the end of the measurement assessment period under the denominator exclusions.
So just to, are you referring to Prep 12 or the MH1 depression
12.
remission measure? Okay.
Yearly. Because I have a patient with an F44.9 dissociative disorder, but the guidelines are saying that is not included in exclusion. So that's why I'd like a little more information on that emotional liable at any time.
Okay. And so looking at the measure specifications, that particular exclusion that you're looking at is only present within the MH1 measure. So my suggestion would be to take a look at the coding documents to ensure that even reviewing the code descriptions to see if something within that coding document captures the particular exclusion that you're looking at. And then it would, the time frame would need to fall within the parameters of the measure. So that measure assessment period is the 12 months plus or minus 60 days from the PH9 score plus the diagnosis associated with that. So we can start there. And if you want some more in-depth help just to confirm that, you can always submit a ticket to qpp@cms.hhs.gov and our team can take a closer look at that for you.
Okay. That would be good. Okay, thank you.
You're welcome.
Thanks, Lisa. Katie, the next question's also for you, and the question states, for Prep 13 statin therapy, if a patient is not qualified for measure because they are allergic to a certain statin, but we find that they are taking a different statin, should we remove the exclusion and report on the statin they are taking?
Hi, thank you for this question. So just want to clarify a couple of things here. So with this particular question, the allergy, statin-associated muscle symptoms or allergy to statin medication is a denominator exception. So when it comes to denominator exceptions, a patient is eligible for the denominator, but the measure specification defines a circumstance and whether they may be deemed appropriately a denominator exception. However, if the patient meets performance for the measure, you can still include them as performance met. So this sort of allows for some exercise of clinical judgment, whether the denominator exception is selected or if the patient is considered complete for reporting based on taking an appropriate statin as specified by the measure.
Thanks, Katie. The next question in the chat is for Deb, and it asks, if CMS pre-populates no encounter for the August 1st, 2023 to December 31st, 2023 timeframe, can we change it to an exclusion if we have documentation that the member refused the vaccine?
Thank you. No, you cannot change no encounters. The no encounter is basically letting you know that the patient was not sampled into that flu season. So like any other measures where the patient has not been sampled, you cannot add patients regardless of what you're finding for receipt or refusal of a flu vaccine. Thank you.
Thanks, Deb. The next question is on the line from Yamini. Yamini, we have unmuted your line if you would like to unmute yourself.
Hi, can you hear me?
Yes.
Okay. My question was, if a patient, there is a patient who has, for a statin measure, who has a diagnosis of peripheral arterial disease with ICD I-73.9, and this patient, if will qualify for statin measure diagnosis because this patient doesn't have a high HDL, high LDL, or doesn't have a diabetes mellitus, and patient is on active statin. Will this patient be excluded from the measure, or this patient will qualify based on the diagnosis ICD I-73.9 for PAD?
So I think this might be one that we would want to take a closer look at via a service center ticket. So my recommendation would be to submit this question to qpp@cms.hhs.gov. And just note that it's for 2023 CMS Web Interface reporting, and then we can take a closer look at this for you through that channel.
All right. Thank you for that question. The next question in the chat is also for Katie. For Prev 13 statin therapy, our staff is questioning why E78.2 mixed hyperlipidemia is not a qualifying diagnostic code for this measure. They believe clinically that this is a risk factor for CVD.
I thank you for this question. So the measure steward has clarified that hyperlipidemia is not included as a diagnosis to confirm denominator eligible patients for this measure. So our recommendation here is to use the coding document as provided within the 2023 CMS Web Interface Prev 13 coding document to identify and confirm appropriate diagnoses for patients. Thank you.
Thanks, Katie. The next question we have is for Angela, and the question reads, for MH1, if a PHQ-2 is completed with a score of 0 during the MEAS assessment period, can we count that as remission?
Hi, this is Angie. No, you can't. The acceptable tools for the MH1 measure are either the PHQ-9 or the PHQ-9M. So a PHQ isn't acceptable to demonstrate remission, and all 9 questions have to be answered on the PHQ-9. Thank you.
Thanks, Angie. The next question we have is for Katie. For Prev 13 in the coding document and on the denominator codes tab, there's an S&M code with a description of hypercholesterolemia disorder. So not specifying familial hypercholesterolemia. Based on this, can we use a diagnosis of hypercholesterolemia to include the patient in the denominator?
Hi, thank you. So even though that SNOMED code is included in the coding document, we do want to note that coding alone is not sufficient documentation. So you might see that code present, but there should be other medical record documentation available supporting the diagnosis of familial hypercholesterolemia in order to confirm that patient. Thank you.
Thanks, Katie. The next question's for you also, and it's common to see coronary artery disease listed in record with no ICD billing code. Coronary artery disease seems to fall under ASCVD by definition. Since billing codes are not required, can coronary artery disease with no listed ICD-10 be counted as ASCVD?
Hi, so again, we would just point you to the coding document for PREV 13, and we would want to ensure that your documentation supports the codes and codes descriptions that are available for the measure within those. How specifically you document in your medical record is up to your organization, but we would look to confirm that the appropriate diagnosis, whether it's descriptors or a combination of codes and descriptors, are available within your medical record to support the appropriate diagnosis for the patient within the various populations for PrEP 13. Thank you.
Thanks, Katie. The next question we have is for Carol, and the question reads, for PrEP 5, a provider note on November 22nd, 2023, has a documentation, patient had screening mammogram in 2021 within normal limits. Would this be considered as passing the measure?
Hi, this is Carol. We cannot provide specific feedback regarding whether or not your documentation in the patient's medical record would meet the intent of the measure. The numerator guidance in this measure specification states that the following are needed: a date and type of the test and the result or finding. So that would be up to you to find the medical documentation to support that. Thank you.
Thanks, Carol. Our next question is for Katie. For patients that are institutionalized due to severe cognitive and physical disability but are under 66 years old, is there an appropriate exclusion available? Is this an example of when we would submit for CMS consideration for skipping? And just for clarification, this is for colorectal cancer screening.
Hi, thank you. So for the frailty and advanced illness denominator exclusions, those would only apply as they're outlined in the measure specification. So specifically for PrEP 6 in this instance, it would apply to patients who are 66 years and older. If you would like to submit a skip request if there is a special circumstance that would have prevented you from completing the quality action on a particular patient, you can certainly do so. We would just request that you be as detailed as possible, citing the reasons why perhaps the screening couldn't be performed, which screenings were attempted, if any, and be very detailed. So I can't necessarily provide a blanket response, not knowing the details, but if you want to submit a skip request, then we can take a look at those on a case-by-case basis. Thank you.
The next question is for Carol. The question is, for Care 2, if an encounter note states gait normal, is this acceptable as an assessment for fall risk?
Once again, can't confirm your medical record documentation. However, what is necessary can be found on page 8 of the measure specification as it relates to numerator guidance, which is documentation of no falls is sufficient. Medical record must include documentation of the screening performed. Any history of falls screening during the measurement period is acceptable as meeting the intent of the measure. And a gait or balance assessment meets the intent of the measure, and screening for future fall risk may also may be completed during the telehealth encounter.
Thanks, Carol. The next question is for you as well. And that question reads, for HTN measure, for the most recent blood pressure reading, Can a nurse blood pressure check be used even if we did not bill it out using one of the encounter codes on the encounter code list?
Hi, and for this question, the clinician can be anyone the organization deems qualified as anyone that is qualified to for this for documentation. Sorry, I stumbled there. Anyway, thank you.
Thanks, Carol. The next question we have is for Deb, and the question is, for Prep 7, would documentation of permanent refusal from previous flu season count towards a medical exception?
Thank you for this question. The medical record should support that the refusal, exception, or receipt occurred during the appropriate time frame. So Prep 7 documentation should be during the measurement period and be specific to the flu season being reported. As long as the medical record documentation supports that the quality action or exception submitted is relevant to the flu season being measured, it would be considered acceptable. Thank you.
Thanks, Deb. Our next question's for Kara, and the question reads, how do we respond to measures where the clinic office closed during 2023 and there's no access to records? Some of the measurement information was gathered prior to the office closing, but for the rest, what's the best selection for this situation?
Yes, thank you. This is Kara with the ACO POS team. By virtue of being sampled into the web interface, CMS has identified claims for these patients submitted by your ACO. In order to be chosen, these patients each have had at least 2 eligible services with the ACO during the measurement period. CMS expects organizations to be able to obtain medical records for these patients, including collaborating with physicians, staff, or facilities inside and outside the ACO. There is an option within the web interface to select medical record not found. That should only be used if there's truly an inability to locate and access the patient's medical record. Thank you.
Thanks, Kara. Our next question is for Deb, and the question reads, documentation of smoking status is usually auto-populated from a previous encounter in the EHR that may not be done during the measurement period.
Thank you. So the intent of the Prep 10 measure is to determine if the patient was screened for tobacco use at least once during the 2023 measurement period. So your documentation should support that the screening occurred during 2023 in order for the measure to be met. Thank you.
Thanks, Deb. We are getting near the end of our question queue in the chat, so just a reminder to please submit any questions you may have. You can also use the raise hand feature to ask a question over the phone, and we will unmute your line for you to ask your question live. Moving along, if a patient has dementia, but it is not on one of the dementia medications listed, can we still skip it as an exclusion? And Katie, this question is for you.
Hi, thank you. So in order to report the exclusion for frailty and advanced illness, your patient would need to meet all criteria outlined for one of the exclusions. So in this instance, they would need to have the appropriate dementia medication if that's what is required for the particular exclusion that you are trying to report. So just to paraphrase, you would need to ensure that they are meeting all of the criteria outlined in the particular exclusion. And that would include dementia medication if that's the one you wish to report. Thank you.
Thanks, Katie. The next question we have is for Carol, and the question reads, for fall screening, are functional status assessment questions such as, are you having difficulty walking or climbing stairs acceptable to capture gait, balance, or fall risk?
Again, any any capturing of falls screening is acceptable. So documentation of no falls is sufficient. There isn't a specific assessment tool that is necessary for obtaining a gait or medical record documentation of gait or assessment of falls. It just has to be in the medical records. So any history of falls screening during the measurement period is acceptable as meeting the intent of this measure.
Thanks, Carol. Our next question in the chat is for Katie, and the question reads, can we count a statin allergy listed on the medication list that is active but noted years prior?
Hi, thank you. So for this denominator exclusion, you would need to support that it is active at any time during the measurement period. So you would just need to be able to support that the patient allergy was active during the measurement period, and that would be acceptable. If the documentation isn't available to support that, then it would not be appropriate to select the exclusion. Thank you.
Thanks, Katie. Our next question's for Angie, and the question reads, if patient has eligible exclusions but has completed a mammogram, do we report the mammogram or the exclusion of the patient? Angie?
Hi. If a denominator exclusion applies to the patient, then the exclusion should always be reported, regardless of whether the quality action, or in this case, a mammogram, was completed or not. This will ensure that the intended denominator population is captured for the measure. Thank you.
Thanks, Angie. And another reminder that we are still accepting questions over the phone or in the chat if you have a question you would like answered live on today's webinar. That being said, we'll move along in the chat. And our next question is for Carol. And the question asks, for HTN2 blood pressure measure, does pain injections OV with ortho or Mohs visit count? For some, they are receiving lidocaine mix or other injections the day of the procedure.
So for this particular instance, since they are not holding any food or the day of, or like for procedure per se, this would also be included in your blood pressure reading. So you could go ahead and use that visit.
Thanks, Carol. Our next question's for Katie. What is the process to receive a CMS other reason? The email ticket system does not provide this exception.
Hi, so the process to submit an other CMS approved reason request, or also referred to as skip request, is within the CMS Web Interface tool itself. So you can, is the patient qualified for this measure step? It will ask yes or no, and there is a hyperlink for no request other CMS approved reason. So once you click that link, it will populate a form for you to enter your email address and to provide a description as to why that particular patient is not qualified for the measure. And then you click request CMS approval. So each of these is reviewed individually as they come in. We just ask that you review the measure specifications to ensure you're not requesting a skip for anything that might otherwise be captured in a denominator exclusion or exception, and to please be very detailed as to your reasoning why this patient should be skipped. So the more information that you provide within the request, the easier it is for it to be processed. And then any follow-up communication will come through the CMS Web Interface support mailbox, and we'll communicate with you via that channel to get any additional information. And if you need a reference, this information can also be found starting on page 45 of the CMS Web Interface user guide, which is available in the QPP resource library. Thank you.
Thanks, Katie. Our next question in the chat is for Carol, and the question reads, For HTN control, if the last BP comes from a Care Everywhere encounter, can we use it, or do we go to the last outpatient blood pressure taken in the ACO?
So for this, okay, so for hypertension 2, if this visit is considered a visit that is inpatient stay or an ED type of a visit, then it would not be used because they are not acceptable for the measure. However, if the encounter is an urgent care or just a regular office visit, then this could be included. Thank you.
Thanks, Carol. Our next question is for Deb, and the question states, if a patient had an encounter during the October to December 2023 with a declination of the flu vaccine and then has an encounter during the January to March 2024 timeframe, would the declination of the flu vaccine during October to December count, or will they need an additional declination documented during the January to March 2024 timeframe? Also, does it count if the flu vaccine is documented declined at the visit, or does it have to specify the 23-24 season?
Thank you. So a couple of things being asked here. I'm going to start with the question about the October 2023 to December 2023, where there is a documentation of patient refusal of the flu vaccine. That would be acceptable if that same patient happened to be included in your sample next year for the same October 2023 through March of 2024 flu season. So the 2023-2024 season, that is still within the appropriate time frame. It's still within that single flu season. So that would be acceptable. What I was referring to earlier, and I think what answers the second part of your question, is your documentation needs to support that the patient refusal occurred during the flu season being reported. So if you're reporting a patient refusal during the 2022-2023 flu season, then if you have patient refusal between October of 2022 through March of 2023, that would be acceptable. If that didn't quite answer your question, please either place another question within the Q&A box and I'll try and answer it more clearly. Or if the call comes to an end and you still have additional questions, please feel free to open up a ServiceNow help desk case and we will answer it in that manner. Thank you.
Thanks, Deb. Our next question is for Angie, and the question asks, for MH1, if there are multiple PHQ-9 during the time period, which screening should we choose?
I guess I'm not sure if this is referring to the screening that would make the patient denominator eligible, or if it is for the numerator. So I'll just speak to both. So if it's to confirm the denominator, you're going to confirm they have the active diagnosis of major depression or dysthymia during the denominator identification period, which is November 1st, 2021 through October 31st, 2022. So you do that first, and then you determine if they have one or more PHQ-9s or PHQ-9Ms administered during that same period. And the one that you would select for the one that would put the patient in the denominator would be the first instance where there is both PHQ-9 or PHQ-M greater than 9 that also has an associated diagnosis of major depression or dysthymia during that same denominator identification period. So all three things have to be present, and then that would be that would mark the index event date. So then if you're looking for the numerator, the index event date is going to mark the start of the 14-month measure assessment period where you're going to look for the numerator. And that's going to be 12 months from the date where both the PHQ-9 and the diagnosis were present. So it's going to go 12 months from then, plus or minus 60 days. And if you have more questions, yeah, please do submit a ticket anytime, and we'll try to get you a more detailed answer. Thank you.
Thanks, Angie. Our next question is for Prince. The question asks, I am wondering why, if CMS uses Q3 files to determine a web interface sample, what then is the rationale for including the current flu season in PY 2023 web interface flu measure sample when many patients have flu vaccines after October? Prince?
Hi, this is Prince from ACO PAOS. So the web interface sample uses Medicare administrative data, i.e. claims data from January 1st of 2023 through October 31st of 2023. As in prior years, patients are only sampled for PrEP7 if they had a qualifying visit with the ACO during the flu season. So for performance year 2023, where patients may be sampled for one or two flu seasons. So for the flu encounter timeframe that spans from October 1st, 2023 to October 31st, 2023, performance is assessed on flu immunizations administered from August 1st of 2023 through December 31st of 2023. Thank you.
Thanks, Prince. Our next question in the chat is for Deb, and the question asks, one of the patients has a different date of birth listed than what is in our charts. It's off by just a few days, so how should we proceed?
Thank you for this question. And there could be other SMEs on the call that want to add some additional information. But just note that you are able to update the patient date of birth demographic if necessary. And there are times when you update that demographic that the patient could end up not being qualified for the measure in which they've been sampled, in which case it will automatically skip that patient and replace them with another patient. However, please note that any demographic information you changed in the CMS web interface doesn't get reported back to the Medicare patient enrollment database, and you should encourage your patient to contact the Social Security Administration directly to have this information updated. Not sure if anyone else on the call wants to add some additional information in regards to updating that patient demographic or not.
This is Carrie. That was an excellent explanation, and it's very simple to make that change in the web interface, but it is, as mentioned, very important to recognize that your changes in the web interface are only in the web interface and are not delivered up or downstream from that tool.
Thank you both. The next question in the chat is for Katie. The question reads, for PREV13 statin, if an allergy to statin is noted in 2023, but there is no allergic response noted, may we accept that as an allergy to statin?
Hi, so the denominator exception for this is patients with statin-associated muscle symptoms or an allergy to statin medication. And the denominator exception should be active during the measurement period. Your documentation should support the patient allergy was active and if present in the patient's medical record, accompanied by an appropriate conditional reason why the patient isn't taking the drug. So in short, your medical record documentation needs to be able to support your use of the denominator exception, and it must be active during the measurement period. Thank you.
Thanks, Katie. And this is just another reminder that you can call in to ask questions if you would like, and we'll unmute your line so you can ask the question out loud. You're also welcome to submit a question via the Q&A box. That being said, our next question is for Deb, and the question reads, for Prev 7, if we cannot find a visit encounter during the flu season date range in our EMR, but there is a vaccine given indication in the sample files, do we have to mark this patient as no because the visit was not documented?
This is Deb. No, basically with the Prev 7 and many of the other measures, we are not asking you to confirm the encounter. That has been confirmed when those patients have been provided as part of your sample. You do typically confirm things like diagnosis if that is something you need, but for Prev 7, you do not have to confirm a diagnosis. You also don't have to confirm that encounter. If you have pre-filled yes, that is one of, I believe, the only measure where there is pre-filled information is yes. And if that occurs, you do not have to do anything additional. If you have no and you are able to confirm that the patient received a flu vaccine, you would want to change that no to indicate that the patient did receive the flu vaccine. Or if there is documentation of patient refusal during the appropriate time frame, that would be another option for you to select. So you don't have to just basically ignore the fact that you can confirm the vaccine was provided just because you aren't able to confirm the encounter, as that encounter has been confirmed for you. Hopefully that answered your question. If not, as we've previously said, you can restate the question in the Q&A or open up a ServiceNow help desk case, and we will continue to work with you. Thank you.
Thank you. Our next question is for Carol, and the question reads, if a patient had palliative care referral and palliative note documented that patient has refused comfort care, then that patient should qualify for the measure, correct?
So in this instance, we may need you to open a help desk inquiry. May submit your inquiry to the QPP Service Center at QPP at cms.hhs.gov. Or by calling 1-866-288-8292. We may need additional information. This patient may not actually qualify for some of the other measures within the specific or within the web interface. So we might need to know a little more information. Thank you.
Thanks, Carol. Our next question is for Kara. And the question states, for DM2, are all patients chosen for the sample known to have diabetes?
Yes, this is Kara with ACOPOS. Yes, all patients in the sample were identified using Medicare administrative claims data as having at least one eligible encounter with a documented diagnosis of diabetes in an office or outpatient setting during the measurement period or during the year prior to the measurement period. Thank you.
Thanks, Kara. And just another reminder to submit questions via the Q&A or use the raise hand feature to ask a question over the phone line. Our next question in the Q&A is for Katie. And the question asks, if a patient is deceased in 2024, do we still need to complete metrics sampled for 2023 or document that the patient is deceased? Katie?
So in order to select not qualified for sample due to the patient being deceased, you would only select this option if the patient died during the measurement period. And the measurement period is defined as January 1st through December 31st, 2023. So if the patient passed away in 2024, that wouldn't be applicable in this scenario. You would still need to report based on what occurred during the measurement period as of December 31st, 2023. Thank you.
Thanks, Katie. Our next question is for Deb, and the question asks, when searching for CMS pre-populated exclusion codes in patient records, but are unable to verify the exclusion codes within the patient available records, do we just accept the exclusion without verification or just note that unable to verify the pre-populated data?
Thank you for this question. And I'll be honest, I went ahead and tagged this one because I am unaware of anything pre-populated for an exclusion. I believe that the exclusions are something that you need to verify based on your medical record findings. However, if there's others on the call that can provide some clarity that maybe there are some pre-populated exclusions where you can help this person out. Otherwise, if nobody is able to speak up and we are unaware of any pre-populated exclusions, I would recommend, if you're finding something like that, to go ahead and open up a help desk question. Thank you.
Thanks, Deb. Our next question is for Angie, and the question asks, does Alzheimer's or dementia exclude from MH1 or MH12?
Hi, this is Angie. There is no MH12 measure. I think you probably are referring to the PREV12 depression screening measure. And then, of course, the MH1 depression remission at 12 months. So there aren't any denominator exclusions for Alzheimer's or dementia on either of those measures. And those measures don't include the frailty advanced illness exclusions that are used on some of the other web interface measures. So I would refer you to the denominator exclusions that are shown in the measure specifications. And you can also refer to the denominator exclusions tab in the corresponding coding document for each measure for codes and conditions that are excluded. Thank you.
Thank you. And just another reminder that you can submit questions via the Q&A box, or you can use the raise hand feature to ask a question over the phone, and we will unmute your line. The next question that we have is for Deb, and the question is asking for clarification on if CMS does pre-fill for PREV7, no encounter, which cannot be changed per CMS. Deb?
Yes, and that is correct. If you see no encounter for PREV7, that cannot be changed. And again, no encounter is indicative of the patient was not sampled for that particular flu season, which is why that cannot be changed. You do not have to do anything additional for PREV7 if yes has been pre-filled. That is showing that CMS through claims was able to find a flu vaccine during the appropriate time frame. So you are done at that point. You may want to change a no, certainly for PREV7 if you find medical record documentation that the patient did receive a flu vaccine during the appropriate time frame, or there is documentation of a denominator exception. So in those cases, you would want to change the no to the appropriate selection. But no encounter, once again, is not something that can be changed in the CMS Web Interface, and that is because it is tied to sampling, and we won't have you adding patients to your sample. Thank you.
Thanks, Deb. The next question we have is for Katie. For PREV13, if the patient does not have a diagnosis of ASCVD, but does not have elevated LDL greater than 190 and is not a diabetic, but is taking a statin, are they considered as not met, or are they just not qualified for the sample?
Hi, thank you for this question. So as stated earlier, hyperlipidemia is not considered a denominator eligible reason to include the patient within this measure. So as you're reporting, you would sort of work through the flow of the different denominator confirmation for each population. If the patient cannot be confirmed in any of the denominator populations, once you get to population 3 and select no diagnosis, the patient will be skipped, and then another patient must be reported in their place if available. They'll only be skipped from the measures for which the option is selected, and not all CMS Web Interface measures. Thank you.
Thanks, Katie. That was the last question we had in our queue. If anyone else has a question they would like to ask, we encourage you to raise your hand now so we can ask the question or answer the question over the phone, or you can put your question into the Q&A box. I see Sandy is on the line and has their hand raised. So Sandy, we have unmuted your line if you would like to unmute yourself.
Hi, thank you. I'd ask the question, it seemed to maybe got past you, but in measures where the denominator includes quote with a visit during the measurement period, are we to confirm that visit, or is that already done for us by CMS? Is that similar to the encounter question that was answered before?
So this is Deb, and I'm going to take that, and actually it just tagged that one within the queue. And there could be some additional information from others on the call. But typically within each of these individual measures, we're not looking for you to confirm the visit because it was based on a visit that the patient ended up in your sample. What I would caution you is there's some measures, say the difference between PREV7, the influenza immunization, and the diabetes, DM2. So DM2, we are looking for you to confirm the diagnosis of diabetes as you're going through that process. But with PREV7, there's no diagnosis associated. It's just a very general visit, and that measure is for just about everyone would be eligible. So we're not asking for any additional confirmation in regards to the visit, just whether or not the flu vaccine was provided. A little different, like I said, to some of the other measures that have diagnosis associated with them, where you're also confirming that that person does meet the denominator based on diagnosis. Does that help, Sandy? Okay, not hearing anything. I'm going to assume that answered your question, but if you have additional questions, please either raise your hand again and we'll get back to you, or we'll look for something additional in the chat.
Thank you. I'm sorry I went on mute again, but it did answer my question. Thank you so much. Appreciate it.
Oh, you're very welcome. Thank you.
All right, thanks, Sandy, and thanks, Deb. We have a couple of additional questions in the chat. The first one is for Angie, and the question reads, for the diabetes measure, when documenting the most recent HbA1c results in a note during the measurement period, but failing to specify the actual test date, would it be acceptable to consider the date of the note as the test date?
Hi, I would refer you to page 10 in the numerator submission guidance in the specification. It does give a priority ranking of the types of documentation to use that you might have, starting with like the lab report draw date. But the last one is practitioner notes, other documentation. And it also specifies that at a minimum, the documentation must include a note indicating the date on which the HbA1c test was performed, along with the result. And it says if the day is unknown, you can enter the first of the month, such as in the specs, it says like if it's May, you would enter May 1st, 2023. As long as it's the most recent date the blood was drawn for the HbA1c and you do have the results, it can be used if it's in the medical record. Thank you.
Thanks, Angie. Our next question in the chat is for Prince. The question reads, in measures where the denominator includes with a visit during the measurement period, do we need to confirm the visit, or is this done for us by CMS?
Yeah. Hi, I think Deb had touched on this earlier, but just to restate, again, that by virtue of being sampled, we were able to find a diagnosis for that patient. So that's how the beneficiary was able to be in the measured denominator. Thank you.
Thanks, Prince. Our next question is for Deb, and the question's asking, for DM2, would we need documentation of diagnosis for diabetes?
So I'm going to actually answer this one, and I believe one that's asked earlier. Yes, you would want documentation to confirm the diagnosis of diabetes. An earlier question is asking about if I am seeing patients with prediabetes and no record of type 1 or type 2 diabetes. Is that an exclusion, or do we select none and the hemoglobin A1C result? So for a patient who has prediabetes and not type 1 or type 2 that you can confirm, you should not confirm that patient based on diagnosis. So, the original question, yes, you want to confirm the diagnosis of diabetes to ensure that the patient that is in there, you have medical record documentation that they in fact are denominator eligible based on their diagnosis, because the next step is you're going to have to confirm that their A1C is under control. And if you can't confirm the appropriate diagnosis, then you will not confirm the diabetes, and that patient is not considered denominator eligible. Thank you.
Thanks, Deb. The next question we have is for Angie, and the question asks, for PREV6, is a Cologuard acceptable? And if it is it for every year or every 3 years?
Hi, you can find this information, the same question on page 30 of the CMS Web Interface frequently asked question document, asking if a Cologuard test counts. And yes, it does. It is considered a fecal immunochemical DNA test, a FIT DNA test. And as the measure specifications state, those would be current if they were done during the measurement period or the 2 years prior to the measurement period. Thank you.
Thanks, Angie. That was our last question in the queue. So once again, we would like to take this opportunity to remind folks to ask questions either in the Q&A box if your question has not yet been answered, or now would be a great time to use that raise hand feature to ask your question over the phone, and we will unmute your line. All right, it looks like we have another question in the chat. The question's for Katie, and just asking you to repeat your response to the question on if a member has an active statin allergy but no reaction listed.
Hi, so for the PREV13 denominator exception, the measure specification outlines that your documentation should support the patient allergy to the statin and that it was active during the measurement period. So beyond that, the measure specification isn't prescriptive as to what specifically needs to be documented in order to support, only that the allergy is documented and that is documented as active during the measurement period. Thank you.
Thanks, Katie. So once again, we have reached the end of our question queue. Again, going to encourage folks to call in and use that raised hand function to ask your question over the line. We also still have the Q&A box open if you would like to send in your question that way. And as a reminder, to keep your question anonymous, please check the send anonymously box. Otherwise, everyone who is on this webinar will be able to see who asked the question. Okay, seeing no more questions, we are going to go ahead and conclude the Q&A portion of this webinar. So I will turn it back over to Sandra Adams-Slaughter at CMS to conclude the call.
Thank you to all for joining today. As a reminder, the slide deck, recording, and transcript from today's call will be available on the QPP webinar library in the next 2 weeks. The next CMS Web Interface support call will occur on February 21st, 2024, and will cover frequently asked measure questions related to DM2 and Prev 12. Thank you.